does it matter? Is there a significant enough difference between the blood pressure results you'll get from just kind of the standard measurement of just sitting down and getting your blood pressure measured right away versus the protocol used in the sprint trial? And what they found was that there were significant differences in terms of the blood pressure results on average between these different protocols. This could lead to negative effects in both directions, either because you're unnecessarily taking an antihypertensive medication when you didn't actually need to, and now you're putting yourself at greater risk for adverse events, or because you're underestimating your risk of cardiovascular disease in terms of the impact of your blood pressure. Hey, everybody. Welcome to post number 3 of the Talking Studies series, a series where I break down individual research papers that I've read and that I think will be useful for you and that I think are generally interesting. Today, we're going to cover a research paper called Implications of Blood Pressure Measurement Technique for Implementation of Systolic Blood Pressure Intervention Trial Sprint. So this kind of feeds off of post number 2, where we covered the sprint blood pressure trial, where they were pretty much testing whether or not more intensive blood pressure lowering protocols that get blood pressure below 120 millimeters mercury systolic are better or have a significantly better reduction of cardiovascular disease events than the sort of standard treatment protocol at the time, or target at the time, which was lower than 140 millimeters of mercury. And just for a kind of brief recap, they found that over just a little bit more than 3 years, when they had to stop the trial early due to ethical reasons because they saw significant differences between the groups, they found a 25% reduction in their primary composite outcome, which was the combination of a bunch of different cardiovascular events, as well as death from cardiovascular causes. They also found a 27% reduction in death from all causes and a 43% reduction in death from cardiovascular causes. And notably, they also found a pretty meaningful, in my opinion, numbers needed to treat to prevent these events or outcomes. Just a quote from the study, quote, "The numbers needed to treat to prevent a primary outcome event, death from any cause, and death from cardiovascular causes during the median 3.26 years of the trial were 61, 90, and 172, respectively," end quote. So if we look at that first data point, basically you need to treat 61 individuals over the span of 3.26 years in order to see a reduction in an event being one of those from the primary composite outcome that I just described. So pretty much that trial was, I don't know if groundbreaking is a little bit of an exaggeration, but it was a pivotal point in hindsight where researchers and medical professionals started to look at lowering even more aggressively than we thought was important before. And this follow-up study that we're going to break down today looks at sort of applying that finding to, or looks at clinical applications. Specifically, they pay attention to the details of how blood pressure was measured in the sprint trial, because it was a bit more extensive than what I think most people see or experience at their primary care office, or just when measuring their blood pressure at home. Quote, "There's been much debate in recent years about what the treatment targets should be for blood pressure control among hypertensive people, whereas the current guidelines recommend a blood pressure target of less than 140 over 90 millimeters mercury. Among those with hypertension, the recently released results of systolic blood pressure intervention trial Sprint challenged this notion. The results of Sprint showed that when blood pressure was targeted to less than 120 millimeters mercury, compared with the higher target of 140 millimeters mercury, the hazard ratio for cardiovascular morbidity and mortality was reduced by 25%. What has received scarce attention is that the method of measuring blood pressure in Sprint was, as expected, research grade. Measurement was performed after a mandatory seated rest in a quiet room for 5 minutes, after which 3 recordings were made at 1-minute intervals. No observer was present in the room during the measurement. The average of these recordings was used to target blood pressure in the participants. In the office setting, blood pressure recordings using meticulous methods such as those recommended by the guidelines and those used in Sprint are often not made. Accordingly, it remains unclear whether the blood pressure targets used in Sprint can be implemented in the general population if routine methods of blood pressure measurement are used," end quote. So pretty much the whole point of the study was to answer the question, does it matter? Um, is there a significant enough difference between the blood pressure uh, results you'll get from just kind of the standard measurement of just sitting down and getting your blood pressure measured right away versus the protocol used in the sprint trial? And if there is no significant difference, then it's okay to just do kind of the ordinary measurement. But if there is a significant difference, then it probably makes sense and it probably matters how your blood pressure is being measured, particularly pertaining to this kind of attention to the details used in sprint if we're trying to translate the results from the sprint trial to kind of everyday people. And so in order to test this, they gathered participants from a renal clinic and a general medicine clinic, all of whom had chronic kidney disease. And another important piece of criteria was that their blood pressure was below 140/90. Quote, participants were recruited from a renal clinic and general medicine clinic at the Richard L. Rudebush Veterans Affairs Medical Center in Indianapolis, Indiana. As detailed previously in a report, to participate, patients had to have blood pressure measured in the clinic on the day of recruitment, blood pressure in the normotensive range, i.e. less than 140/90, and evidence of chronic kidney disease. We excluded those with kidney transplantation or dialysis and those receiving immunosuppressive drugs, end quote. Going on just a little more detail on the baseline characteristics of the individuals in the study. Quote, of the 333 participants recruited, 275 had echocardiograms that form the basis of this report. Ages ranged from 38 to 89 years. 65% of the participants were aged greater than or equal to 65 years, and 32% were aged greater than or equal to 75 years. There was diversity in race, with 17% of participants being black. However, 98% of the participants were men. About 65% had underlying diabetes mellitus, and there was a high prevalence of cardiovascular disease. For example, approximately a fifth each had coronary artery bypass grafting, peripheral vascular disease, or a prior hospitalization for heart failure. The distribution of chronic kidney disease stages was as follows: 5% stage 3A, 35% stage 3B, 52% stage 4, and 7% stage 5. Only 2 participants had an estimated glomerular filtration rate of greater than 60 milliliters per minute per 1.73 meters squared. Albuminuria stage 2 was present in 22%. Stage 1 was present in 27%, and 51% had no albuminuria. Of the 275 participants, 269, or 98%, were being treated with antihypertensive drugs. The mean number of antihypertensive medications was 3.1, end quote. So notably, if we look at the subjects in the actual sprint trial, they all were assessed as having elevated or increased risk of a cardiovascular disease event based on having one of several criteria, or at least one of several criteria. Some of the criteria, just off the top of my head, were, I think, being older than 75 years old, having maybe previous cardiovascular, having like hypertension or kind of signs of or symptoms of metabolic syndrome, stuff like that. And notably, this group of subjects, although they're slightly different in that all of them have chronic kidney disease, they are generally, I'd say, have some increased risks of cardiovascular disease. In particular, one thing that sticks out to me is that last piece where 98% of them were being treated with antihypertensive drugs, and the mean number of antihypertensive drugs was 3.1. So on average, pretty much all of them are taking antihypertensive medications or medications to lower their blood pressure. And on average, they're taking 3 of those medications. If we think back to the sprint trial, the group using the intensive blood pressure lowering group was taking on average 2.8, so close to 3 blood pressure medications by the end of the study. So the two do map up or match up quite similarly in this regard, which I think is important if we're trying to compare the two. Now, moving on to the actual testing procedures, as the last quote sort of alluded to, a part of this was that each of the subjects got an echocardiogram, which, as I understand it, is an imaging technique using ultrasound to look at the heart and measure different kind of the sizes of different parts of the heart, or just kind of look at the health of the heart from a structural standpoint. And the reason they did this was, in addition to kind of having the sprint the results from the sprint trial as the background for basing whether or not the more extensive blood pressure measurement protocol is sort of useful or valid. They were, in addition, comparing the association of the different blood pressure protocols, which I'll go over in a second, to left ventricular hypertrophy, which is kind of a sign of increased stress or strain on the heart. If you remember anything from like basic anatomy class, the heart has four chambers: the right atrium, right ventricle, left atrium, and left ventricle. Blood comes in through the right atrium to the right ventricle, goes to the lungs, then comes back to the left atrium, goes to the left ventricle, and that's the last chamber the blood goes through before getting pushed out to the rest of the body. And since the left ventricle has to push blood out to the entirety of the whole rest of the body, it squeezes particularly harder than the other chambers, as I understand it. And if you have increased blood pressure or some other type of cardiovascular dysfunction, the left ventricle will have to squeeze harder to overcome that pressure and resistance to push that blood out to the rest of the body. And there are other reasons other than just blood pressure that can cause the left ventricle to have to squeeze harder. But generally, when this happens, the left ventricle will work harder. And just like your muscles work, when your muscles work harder in the gym, they tend to grow. The left ventricle can hypertrophy or grow. And this is actually kind of a negative sign of cardiovascular health. So all in all, that's why they did the echocardiograms, to kind of get those measures to match up whether or not the different blood pressure protocols were associated with left ventricular hypertrophy. And speaking of the actual protocols, the research grade protocol involved a very similar protocol to that used in the sprint trial, which is subjects would go to a quiet room alone with no observer. They would sit for 5 minutes, after which they would have 3 blood pressure readings. And I looked through the actual protocols in the sprint trial, and I didn't see anywhere that during the 5-minute rest in the sprint trial that the subjects had their arm elevated to heart level. But in this kind of replication study, during that 5-minute rest, subjects had their arms, their upper arm raised to kind of the level of their heart. I'm not sure if that's exactly how it was done in the sprint trial, like I said, but maybe these authors reached out to them to kind of confirm that that was the case. Either way, kind of the big similarities were, one, that the subjects were resting for 5 minutes before getting their blood pressure measured. There was no observer in the room. It was just an automated cuff to kind of deal with maybe white coat syndrome, or the kind of concept that some individuals, their blood pressure will go up when it's being measured in the presence of other people because they'll get anxious or something like that. And also, notably, they had 3 measurements, and the average was taken as the kind of blood pressure uh, result for this research grade protocol. In the sprint trial, the 3 measurements were split up by 1 minute. So they would come in, rest for 5 minutes, get their blood pressure taken. There would be a 1-minute rest interval, get their blood pressure measured again, and then there'd be another 1-minute interval, and their blood pressure would be measured again. In this follow-on study, they used 30 seconds instead of 1 minute, but they kind of justified it, saying that other research suggests that 30 seconds is sufficient. Quote, after obtaining signed informed consent, participants were invited to our research laboratory. This typically occurred in a fasting state and in the morning. Blood pressure measurement was performed using the Omron HEM 907 oscillometric monitor with a cuff size appropriate for the arm. This device has been validated by several investigators using standardized protocol. Notably, I believe this is also the same exact one that they used in the sprint trials. The monitor was programmed such that the cuff did not start to inflate until the participant rested quietly for 5 minutes in a seated position with the arm at the level of the heart. 3 consecutive recordings were made 30 seconds apart. Although 1-minute intervals were used in sprint, 30-second intervals have been widely used in the National Health and Nutrition Examination Survey. The average of these 3 recordings was called research-grade clinic blood pressure. No observer was present in the room during these measurements. This technique is similar to that reported in sprint, end quote. And so after they got that research grade blood pressure measurement, they then went on, got the echocardiogram, and then afterwards they had their blood pressure taken in what the authors labeled the kind of routine blood pressure protocol, where the subjects were lying on their backs and somebody manually took their blood pressure. Quote, following the echocardiogram, another blood pressure was obtained using a validated device. So actually, scratch that. It wasn't manual blood pressure, but this measurement, however, was made only once by the echocardiographer, who was present in the room at the time of the measurement. The participant was in the supine position during the measurement. We called this routine clinic measurement, end quote. So it wasn't a manual blood pressure. It was still an automatic blood pressure, but the there was an observer, the echocardiographer, the person who did the echocardiograph or cardiogram. Uh, pressed the button, presumably, and was in the room while that measurement was being taken, similar to how I think most people get their blood pressure taken, typically when they go to the doctor's office. And then after this, they had one additional blood pressure protocol, which was a 24-hour ambulatory blood pressure monitoring device, which, as I understand it, they keep on them for 24 hours, just like the name implies. And the blood pressure cuff will intermittently continue to measure their blood pressure over time. Quote, all participants then underwent 24-hour ambulatory blood pressure monitoring using the validated Space Labs 90207 device as reported previously. Participants kept diaries that were used to calculate sleep and wake times. Each participant's medical record was reviewed to ascertain underlying comorbid illnesses, end quote. So that was pretty much the study design. And what they found was that there were significant differences in terms of the blood pressure results on average between these different protocols. First, I'll pull up kind of the graph. This is a Bland Altman graph, as I understand it. I wasn't too familiar, but it's sort of self-explanatory. I did kind of check out some resources to make sure I wasn't missing anything super important. I'll leave a link below to a video I watched that had a pretty simple explanation of kind of what these graphs are, but more or less on the y-axis is the difference between the measurements at hand. So if you have someone go in and get the routine clinic or the research grade blood pressure taken, and then you have their routine blood pressure taken, the difference between those two results is shown on the y-axis, and then the x-axis is the average of the two results. So of particular interest, I think, is the top left graph in this figure, which shows the systolic blood pressure differences between the research grade and the routine measurements. And what you'll see is that the solid line kind of in the middle represents the average difference, which was about 12 millimeters of mercury. And those dotted lines represent the 95% limits of agreement, which are similar to 95% confidence intervals, as I understand it. They pretty much represent what we believe, according to statistical analyses, where what we can predict 95% of the differences will fall into is this range. And we'll get to that in a minute, but you'll see that that's a pretty big range. And also what you'll see is that in the kind of middle section of the blood pressure measurements, so just eyeballing it between maybe 110 to like 160-ish, you'll see that there's a greater variation where some of those measurements are dipping significantly lower. And so to me, what that says is at the kind of fringes, people with the really low blood pressure or the really high blood pressure, there's less of a difference between these two measurements. But for everybody in the middle, there's kind of a greater variation of the differences in blood pressure readings between routine and the research grade protocols. Another thing to note is that although the average difference was that the research grade blood pressure was 12 millimeters mercury less than the routine blood pressure reading, you also see that if we look at an individual scale, and just like the kind of limits of agreement allude to, there are also several individuals that had the opposite kind of difference where the research grade blood pressure was higher than the routine grade. Quote, on average, compared with routine clinic blood pressure, research grade systolic blood pressure was 12.7 millimeters of mercury lower, and diastolic blood pressure was 12 millimeters of mercury lower. Notably, both measurements were recorded on the same day in each participant. The limits of agreement for systolic blood pressure were minus 46.1 to 20.7 millimeters of mercury, and diastolic blood pressure minus 34.2 to 10.1 millimeters of mercury were wide, end quote. So notably there, if we look at the limits of agreement for the systolic blood pressure, it means that 95% of the differences we predict will be between 46.1 millimeters mercury lower and 20.7 millimeters mercury higher. So there's a wide range of differences when we're looking at the comparison between the routine and the research grade clinic blood pressure measurement. I think this is important on both ends in that if the research grade is significantly lower, that means if you just get the research or the routine clinical measurement, that you may be over predicting how high your blood pressure is and potentially going on blood pressure lowering medication when you don't need to be. And if we remember the results from the SPRINT trial, there were significantly greater adverse events from a relative perspective, at least, between the more intensive blood pressure lowering protocol or individuals in that group compared to the less extensive or kind of standard treatment group. So it could potentially be putting you at greater risk of adverse events if you're inaccurately overpredicting or overestimating your blood pressure. And on the other end, if you're one of the people who has a higher blood pressure reading, or excuse me, a lower blood pressure reading in the routine measurement, then you may be underestimating your risk in not attending to potential increased risk of cardiovascular disease due to high blood pressure because you don't recognize that you have a higher blood pressure because you haven't gotten the proper reading. Anyways, moving on. Quote, research grade systolic and diastolic blood pressure were both lower than the corresponding daytime ambulatory blood pressure. The systolic research grade clinic blood pressure was 7.9 millimeters of mercury lower, and diastolic research grade clinic blood pressure was 11.7 millimeters mercury lower. In contrast, routine clinic blood pressure was 4.8 millimeters mercury higher systolic and 0.3 millimeters mercury higher diastolic. However, for diastolic blood pressure, the difference was not significantly different from zero, end quote. So I'll throw up a table with all of the comparisons between the research grade measurement, the routine measurement, and the ambulatory 24-hour measurement. And like that quote kind of alluded to, comparing the research grade to the ambulatory, there still are some differences in terms of the research grade showing a lower systolic blood pressure, but they're smaller than the difference between research grade and routine grade. And although I think the 24-hour ambulatory is interesting for the purposes of kind of comparing the clinical measurement to this really detailed research grade measurement, I think those are kind of more important from a practicality standpoint because at least as of right now, I don't think a lot of people are using the 24-hour blood pressure measuring devices. Continuing on, they, like I described, looked at the associations between each of these blood pressure measurements and the degree of left ventricular hypertrophy, which I believe was dichotomous. So they simply said, or the results were simply yes or no for does this subject have left ventricular hypertrophy? Quote, to further explore the association of routine clinic and research grade clinic blood pressure measurements, we calculated the odds of echocardiographic left ventricular hypertrophy with each type of blood pressure measurement. Figure 2 shows the odds ratios for each type of systolic blood pressure measured in this analysis. The strength of the association of left ventricular hypertrophy and systolic blood pressure was greater for ambulatory and research grade measurements compared with routine clinic measurements, end quote. So I'll throw up the figure here, and what you'll see is the research grade and 24-hour ambulatory blood pressure measurements had similar associations in terms of predicting left ventricular hypertrophy, while the routine protocol had a lower association in terms of being able to predict left ventricular hypertrophy compared to both of those measurements. So in addition to already kind of having the data from the SPRINT trial to back up that the research grade measurement is the one that we should care about, we also have this data suggesting that there is greater association of the research grade measurement with a pertinent or reasonable marker for cardiovascular dysfunction, which is left ventricular hypertrophy. So that kind of does it for the main results. I guess now to the discussion, or what I like to think of as the so what portion of this post. As we discussed a little bit in the beginning, the whole point of this trial was to answer the question, does it matter if we really pay a ton of attention to how we're measuring blood pressure, or are we more or less going to get a similar measurement if we just kind of show up and measure our blood pressure the way that people routinely do? And I think the answer is pretty clearly yes, it does matter how we measure blood pressure because there are substantial differences that vary from individual to individual in terms of the measurements acquired from this research grade or more intensive protocol and the routine measurement. And I think this is kind of intuitive, and a lot of people have probably experienced this. And it's easy to test in that if you have kind of an automatic cuff or someone who can measure blood pressure at home, I've done this myself where you sit down, immediately just have your blood pressure measured and compare that to when you're sitting for 5 minutes, resting with your arm at the height of your heart. I see significant differences in terms of the blood pressure measurements right there. And I think this is also meaningful considering the factor of having an observer there or not. Especially if you're only getting your blood pressure measured once or twice a year, there may be significant differences just due to novelty or due to anxiety or whatever from having somebody in the room. And it might even be subconscious in that you don't even notice that your blood pressure is increasing due to this, but it may be a significant factor. When I think about this, it kind of makes me think of a lot of exercise science studies where prior to actually testing an individual's one repetition back squat max, for example, they'll have a familiarization session where somebody will go in and familiarize themselves with the movement, with the testing protocol, with the jumps going from just the bar to having 45 pounds on each side to then jump going up by 10% in weight until you hit your max and so on and so forth. Because if they familiarize with that, then they can kind of cancel out any confounding that might occur because subjects weren't as familiar with the protocol when they were actually being tested. And I think the same kind of applies in terms of blood pressure measurement, in that if you're regularly testing or not testing in front of somebody else, it could impact the outcome, as we're kind of seeing based on this data. Quote, adding 12.7 millimeters of mercury to the targeted blood pressure of 120 millimeters mercury systolic measured in sprint yields 132.7 millimeters of mercury systolic. This may be considered the routine blood pressure goal. However, this would be a naive approach, given that the limits of agreement between measurements were wide. As an example, for a target blood pressure of 120 millimeters of mercury systolic, measured using research grade methodology, patients may have differences from routine clinic blood pressure that may be 46.1 millimeters mercury lower or 20.7 millimeters mercury higher, making such recommendations worthless. End quote. So, like they're alluding to there, based on the limits of agreement, if you have a measurement of 120 millimeters mercury for your systolic blood pressure, just based on the routine protocol, for all we know, you may actually have a, or I guess it's a little bit less practical. Let's say 160 measurement routine. You may actually have, less than 120 millimeters in terms of your systolic blood pressure, or it may be even 20.7 millimeters mercury higher, and it may be like something like 180. Like I said, I guess it doesn't apply as much based on the graph we looked at to people on the fringes of really high or really low blood pressure. But the point is, there's a considerable kind of gap in what your actual blood pressure, or at least when I say actual, the blood pressure you may want to care about if you're trying to apply this results from trials like Sprint or Sprint specifically. There may be a pretty significant gap, and you may not know or be acting on actually accurate results. Quote, taken together, these findings suggest that if the sprint findings were to be translated to clinic practice, the first step would be to measure the clinic blood pressure as was done in the trial. Without these research grade measurements, the likelihood of harm or lack of benefit may be real, end quote. So that kind of gets to what I was talking about before, where either if uh, your blood pressure based on the research grade protocol is higher or lower than what you're getting in a routine measurement, this could lead to negative effects in both directions, either because you're unnecessarily taking an antihypertensive medication when you didn't actually need to, and now you're putting yourself at greater risk for adverse events, or because you're underestimating your risk of cardiovascular disease in terms of the impact of your blood pressure. And so you're not lowering your blood pressure when in reality it's actually elevated, though you didn't know because you were just basing your kind of actions on this routine measurement that was inaccurate. Um, so yeah, that's kind of the interesting findings or thoughts I had after reading this research paper. I think it's um, pretty interesting and pretty relevant. You can go maybe test out for yourself whether you think there's a big impact, and I think most people will find that there is. And like I said, it's kind of intuitive. I remember working in as a medical assistant in a pediatrics office. We also had, although we had a lot of younger kids, we had patients who were between like 18 and 23 years old who were adults, and it was less likely to see blood pressure issues in the younger kids, but in these individuals, it might be, more likely now that they're older. And there were several occasions. It wasn't like it was every patient, but it wasn't uncommon for one of these individuals to show up. I measure their blood pressure; it's high. They go talk to the doctor, and the doctor comes and talks to me and says, "Hey, they were late getting here. They just ran up the stairs and pretty much went right into the chair and sat down and had you." Uh, measure their blood pressure. I'm having them sit right now for a few minutes. We just go back in and check it again, and then I go and do it, and their blood pressure is perfectly normal. So I don't know, just something to consider, something I thought was interesting, something I'm kind of implementing when it comes to checking my own blood pressure. As I've said many times, atherosclerotic cardiovascular disease, leading cause of death globally. So if you care about kind of longevity or health, might be important, or at least I think it's important for those reasons. But that wraps it up here. So thank you for listening. If you want to support the channel, if you want to see more of my content, you can check out the other videos I've made on YouTube or the written and video content I post on Shortcut U on Substack. If you want kind of more organized or succinct posts rather than me kind of mumbling on in tangents like I do sometimes in these videos, the written content there, especially the deep dives I do, I think are pretty nuanced and, like I said, a lot more organized if you're interested in that type of stuff. But otherwise, I will catch you next time.